Hi, I'm Lorenzo Falchi. I'm a lymphoma specialist at Memorial Sloan Kettering Cancer Center in New York City. And this year at ASH, we were very excited to share the first and primary analysis of the global randomized phase 3 controlled trial of epcoritamab plus R squared versus R squared in patients with relapsed or refractory follicular lymphoma. This trial is called EPCORE FL-1, and this was our first disclosure of the data. So this, as I said, was a global study, and the idea of the study is really to improve outcomes for patients with relapsed or refractory follicular lymphoma. We know that the majority of these patients, unfortunately, are not going to be cured of their disease, and the currently accepted standard of care, which is R squared, rituximab and lenalidomide, really is suboptimal. Very few patients are cured with this approach. Most patients relapse within a relatively short period of time in the contemporary era. Epcoritamab had already been approved by the FDA as a monotherapy for patients with relapsed or refractory follicular lymphoma. And we know that combining it with rituximab and lenalidomide could have been a winning move because these two components of the regimen don't have overlapping toxicity. And there may be some synergism or augmentation, mutual augmentation of anti activity. We also know from preclinical data that epcoritamab and rituximab can be co-administered with no interference or minimal interference. We had already published the results of the EPCORE NHL-2 study testing epcoritamab with R squared in patients with recurrent follicular lymphoma, and the results were very promising with high response rates, long duration of benefit, and a manageable safety profile. So in this study, we really ran head-to-head epcoritamab R squared versus R squared. We randomized patients in a one-to-one fashion. The primary endpoints of the study were overall response rate and progression-free survival, both independently assessed. We had a number of secondary endpoints. We really looked at all efficacy and safety measures. We had almost 15 months of follow-up in this study, and we enrolled a total of 488 patients, almost all of which at this point have either completed or discontinued. The patient characteristics were well balanced between the two arms as a randomized study. And we had both low-risk populations, including about 60% of our patients who had received only one line of therapy, but also a higher-risk population. Bulky disease, POD24, patients who are relapsed or refractory to many lines of therapy or primarily refractory to either anti-CD20 antibody or chemotherapy or both. And we were very pleased to see that the study met both its primary endpoints. The epcoritamab R squared combination led to a very substantial 79% reduction in the risk of progression or death. And the hazard ratio to that comparison was 0.21, very statistically significant. Twice the number of patients were estimated to be progression-free at 16 months with epcoritamab R squared compared to a square alone. It also led to deeper responses. The overall response rate was 95% in the epcoritamab R squared arm versus 79% in the R squared arm alone. Perhaps even more compellingly, 83% of the patients in the epcoritamab R squared arm achieved a complete metabolic response versus 50% in the R squared arm alone. The duration of those responses was longer, both the duration of objective responses and complete responses. Also importantly, patients had much longer time to next lymphoma therapy. At 16-month, 93% of our patients in epcoritamab R squared arm had not required another subsequent therapy versus less than 65% in patients treated with R squared. We also saw a very early positive trend for overall survival in patients treated with epcoritamab R squared. Almost 96% of our patients at 16 months were alive with this disease. 88% of the patients in the R squared arm were. And when it comes to safety, of course, the addition of epcoritamab comes with additional adverse events, particularly neutropenia and infections. But in neither case, this led to significant rates of discontinuation of either or all study therapy. And we were reassured to see that the fatal adverse event rate was very low in both arms, 2 to 4%. Despite the additional adverse events, the median relative dose intensity of the Epcoritamab R2 regimen really wasn't compromised, being about 90% or greater for any or all drugs. So in conclusion, Epcoritamab and R2 really demonstrated a clear superiority compared to R2. It led to a massive reduction in the risk of progression or death. It was superior in terms of overall response rate, complete response rate, duration of response, time to next lymphoma therapy, overall survival, a little trend that we started to see. And the profile, again, added adverse events, but manageable. So we really feel that based on all these results, Epcoritamab R2 sets a new benchmark for the treatment of refractory follicular lymphoma.